Hello, everybody. I'm Sigis Molassotsky from Angers, France. It's my pleasure to co-chair this session with the amazing Beverly Hunt, you probably know. And we will start directly with Fries Dietmar from Innsbruck, who will talk about the pre-hospital management in polytrauma patients. Thank you.
Great honor for me to be here. My name is Dietmar Fries. I'm head of the trauma ICU in Innsbruck, and topic is pre-hospital management. So here you see my conflicts of interest, believe me or not, but I tell you only the things we do or not do in clinical practice. So this is my hometown, and as you may think, we are more or less also confronted with trauma, especially in not that easy regions when we have all kind of victims here in the Alps. So I want to focus this 15 minutes especially on bleeding, since bleeding is almost one big contributor to death in trauma patients, as you can see here. And let's go very quick through all the possibilities of devices we can use for bleeding management in trauma patients. Like this tourniquet. This tourniquet is quite old. It was even used by the Romans. The second picture here is from the First World War, and this is how we use it today. Actually, you should have on board at least 2 of these tourniquets. If one does not work, you can use the second one more proximately and try to increase the pressure. Quite easy to use. You should check that one time. Pressure should be 70 to 100 millimole mercury above the systolic pressure. In obese patients a bit higher, and use it for 1 to 2 hours, something like that. The pelvic sling also often used wrongly, often too high. That may also aggravate bleeding, which is also often forgotten here is the fixation of the lower legs here and even of the ankles. You have to do some internal rotation, otherwise bleeding hemostasis is not efficiently here done. Invasive procedures are advocated also in some situations for pre-hospital. We don't do. The Reboa system is available. We use it only in the emergency department. There are 3 different sizes you can use it. Below the subclavian artery, above the visceral arteries, and below the infrarenal arteries here. However, if you use it pre-hospital, probably in a vasoconstricted patient, it is a long during procedure, and the risk for dissection is not that low here. So again, we use it only in the ED. The same for pre-hospital resuscitive thoracotomy, the clamshell operation, very effectively done in UK, in London by the HEMS teams. I personally, honestly, I'm not trained in this, and all my colleagues in Western Austria too, we never have done it in my county. However, it is part of the ERC recommendations because of especially the good results of a trained team in London, UK, but I think this is guilty for 1 or 2% of all emergency doctors driving or flying around here. Better results also when this procedure is done in the emergency department, and here also some beneficial effects, not only in penetrative injuries here. Let's go also to some kind of pharmaceutical interventions. I think there is no drug better evaluated than tranexamic acid in the CRASH 2 or 3 and in the women's trial. However, there is some kind of probably overuse of tranexamic acid actually in the clinical routine. That's my impression. We lost one drug. You may remember that aprotinin, because the wrong patients received the drug. However, in the bleeding patients, there is no question not to use it, and there's also some good recommendation to use it even on the road to the hospital, pre-hospitally here with a 1C recommendation in the actual trauma guidelines. Further, local hemostatics for pre-hospital use. There are several bandages available. I want to warn you about the wound studs, the silicate here. It may induce also some kind of embolism that was found in a pig trial here. Actually, the 1B recommendation to use it, the best which seemed to work is Celox bandage, which is a Hitosan bandage, and Hitosan is inducing some activation of the coagulation system due to thrombin activation. However, I think all of them work more or less. We don't have very good clinical data. These are all pig trials done especially by the US Army. Diagnosis, this is probably a late diagnosis, is the back door of our helicopter, and then we have some kind of a scene that the patient was that massively bleeding here on the route to the hospital. Much more sensitive, probably here the ultrasonic examination. We have some kind of small ultrasound device on the helicopters, and I think this is crucial also to follow up the right way for the patient, to bring him to the right hospital where you can do the intervention the patients need, and then not secondary transportation to the center you can leave out then. Whole blood transfusion pre-hospital is a big issue. It's some kind of religious issue probably also. When you go through the data, what is published, there is only low evidence for that and nearly no good results showing that there is any benefit for whole blood transfusion. Whole blood transfusion was done in the First World War and not later on, and I think it's not an evolution like the guys from the TOR group or whatever said. It's more or less a devolution of bringing resuscitation to the patient. Pre-hospital blood component therapy, also some good results from the war zones. However, our city or my city is not a war zone, and it's questionable if we can transfer this probably more or less good experience to a civilized situation here. And I want to remind you that we have some hemoglobin recommendations, target between 7 to 9. And we know that under normovolemic conditions, the hemoglobin level can drop even with no problems of organ dysfunctions here. However, normovolemia should be achieved here. When we look at the last published papers here, like Shackelford or Holcomb, they present data where they more or less have shown that there was some kind of improvement of mortality or outcomes. However, here they transfused at a hemoglobin level of 12 to 13 when patients were admitted with or without pre-hospital transfusion. So I would accuse them, this is more or less a volume therapy which was done with blood components, and this is ridiculous in my mind. Because it's more or less the problem is oxygen delivery capacity. You can improve with some kind of transfusion of something, but easier with improving the cardiac output with volume. And this is cheaper and easier to administer even in the pre-hospital setting. Plasma transfusion pre-hospital, I think you're all aware on the PAMPER study. Here's a decreased mortality by 10% with the administration of 2-FFP. Believe me, 2-FFP is not resuscitative concerning coagulation factors. There's also a recommendation in the actual trauma guideline not to compensate or not to treat hypofibrinogenemia with plasma, and the first factor which is critical is a fibrinogen besides the hypofibrinolysis. So from that point, FFP is not working here. So it was more or less a volume therapy. And when you look at the total mortality, mean ISS in this group was 20, a little bit above here, 21. And mortality of 20 to 30% is 2 to 3 times higher than I would say in the centralized, civilized European situation here. And this is a problem when we deal with data from the US. This is the result of the MOTS registry here, and here's the ISS, and you see the worst outcome. I have our US colleagues here. This is the German trauma database, and this is trauma data we received from West Austria here, so it's much more below. So accepting very uncritically results from the US, I would say maybe going 2 steps back. And these are some results from the East Coast here, where plasma was investigated also pre-hospitally here, and here they didn't found any any benefits, especially mortality, was improved in those patients here who received plasma, but this was not statistically significant. Resuscitation with fluids, we're all afraid when patients receive fluids that say start bleeding because of mechanical issues, increase of blood pressure, but also because of the dilutional coagulopathy. And a lot of authors accuse 500 to 1,000 ml of crystalloid to dilute the patient. I want to remind you, if you do it in a more or less experimental setting, 500 ml of crystalloid even activates the coagulation system. If you do VET testing, you see a shortening of the clotting time. So dilution with at least saline, that's not the issue here. And I also want to remind you that concerning traumatic coagulopathy, hypotension and shock is the main trigger. That means if you avoid fluid resuscitation, if you avoid normovolemia at least, or if you do that permissive hypotension where the patient is more or less at least allowed to be at shock, you do not avoid coagulopathy. That's the point here. And I'm really happy that we heard here probably also some kind of good lecture about the combination of vasopressin here, for example, with fluid, which is a beneficial effect here. This was a protocol done for the special forces from the US. Nathan White has done the study with a big trial here, and he combined fluid and coagulation therapies. That means he had a very complex bleeding situation from the aorta, from the bones, continuously bleeding pigs here, and one group received nothing. This would be more or less a permissive group here. One received Hextant, which is a colloid I would probably never ever use because the side effects, especially on the coagulation system, are really rude. And the third group received fluid or volume, Hextant plus fibrinogen concentrate here. And here you see the results on the mortality. Those pigs who received nothing deceased very quickly. Those who received only fluid or volume resuscitation a little bit later, and the best result was in those who received volume plus coagulation factors. And that's what we have done also in the pre-hospital study in Austria, which we have done also with colleagues in the Czech Republic and in Germany, 12 centers. Here we made a prospective randomized placebo-controlled trial where we tried to avoid coagulopathy in bleeding patients which were at need for volume therapy. That means indication was patient is suspected to bleed and is needed volume, and in Austria we use gelatin for resuscitation fluid, also on the helicopter, plus crystalloid, obviously. And what we avoided here was that coagulopathy. That was the first blood withdrawal in the field. You see very low fibrinogen, and in that situation the patient is not even diluted. That means hypofibrinogenemia is not only the result of dilution with fluid, it's also the result of hypotension and shock and loss of coagulation factors due to bleeding. And this was the amplitude at arrival in the hospital. It improved and was just in the low normal level here. And this was what we achieved here within the study. We could avoid coagulopathy at admission in the hospital here. So let me come to a conclusion. I think what we need in the future is not just route regimes. We need a much more targeted therapy, much more individualized therapy to get some benefits for our patients. Thank you very much.
Thank you very much. Do we have some questions? Can I ask a question? You didn't talk much about time from trauma to getting to a trauma unit. Do you think that's really very important?
I also didn't talk about intubation, and there are so many issues. I wanted to focus on bleeding management, but time is an issue. And all that procedure which I have shown you in the FinTech study were done en route to the hospital. That means administration of fluid in the helicopter, administration of the fibrinogen concentrate, even in the elevator when the doctor brought the patient to the ER. It should not, and that's a good point you made here, it should not delay the treatment on the road and the transportation to the hospital.
Do you
Thank you.
think the difference in time to get into the trauma unit might account for the differences between what goes on in the States and what happens in Europe? Because we have very fast ambulance services and they often go to a primary hospital and then get taken on to a trauma unit to have longer times.
That's also a point, and therefore quick and good monitoring to have an idea of what the initial problem of the patient is, to bring him to the right hospital. Transportation to hospital A, and then they see, okay, we have some indications to bring him to a more centralized hospital. That will delay several hours here.
Yes. Okay. Thank you very much. Really excellent cover of the area. We're moving on now, and we're going to hear about optimal triage. It's great to have Olivier Houet here. He is coming from University of Bretagne in Brest in France. Thank you.
Thank you very much. So we are actually going to talk about time in this presentation because it's when triage takes all its place. So I actually come from Brest, western port of France, COVID-free, so you're welcome to come if you want. It's a fantastic place. Just to remind us that injuries is a leading cause of death, third cause in the world, and first cause of death for young people, and first cause of loss of year of life in this category of patients. So it's a major health issue for us. As we said, the time is critical for these patients because, as you can see in this publication, the majority of the deaths occur within the 21st 4 hours, and cause of death is reported as being hypoxia, bleeding, and traumatic brain injury. So if you have a patient with a chest trauma, if you have a patient with an hemorrhagic lesion or a traumatic brain injury, the risk of death within the 24 first hours are extremely important. So we need to act as fast as we can to avoid. We can't do much about what happened during the accident, but we have to act to avoid the patient to worsen his clinical state. And if you look at so analyzing death in trauma patients is pretty difficult, and because when the patient comes to the ICU or ED department and bleeds to death, we'll say, well, he had a major injury, you can do nothing much, but you have to go back in the history to see if, just in case, the optimal care has been given to this patient, so he might have survived. And a way to see that is to analyze the preventable or potential preventable mortality. And this has been done in 2007 by Texera and co-workers, and they just had a look at the cause of death, and after, if there was something wrong in the initial care that could have been avoided and maybe avoid or surely avoid the mortality, the death of the patient. So, as we said, first cause of death for these patients is bleeding. So this is not something new for us. But the delay and the mistakes that has been made by the doctors are critical in preventable mortality. And you can see that delay takes part of 53%, in 53% of the case in the death, preventable death of the patients. So survival for a trauma patient is a matter of time and a good decision-making process. So you have to put both together. It's not only putting the patient in the ambulance and taking him to any hospital, it's taking him to the proper hospital with the proper team able to treat him. And this is just one example of what needs to be done or should be done in a proper way to diagnose and after maybe treat properly the patient. This study has been published in 2012. This is the team from Paris. They just looked at retrospectively patient who had a whole CT scan or selective CT scan. And they looked at the impact or the association between mortality and the way the imaging was done. And it's definitely, and I think this is not really a surprise, but it's always good to demonstrate it, that it's in favor of whole CT scan instead of selective CT scan. This means that you have to bring the patient to the right place with a trained team, and it's a multidisciplinary approach. So if the radiologist is not trained in the acquisition of total body CT scan for traumatic patients, you may miss a diagnosis of bleeding or a lesion that you could treat, and that may cause worse the outcome if it's not done. So from this point, we now all know and hopefully believe that trauma patients should be taken to level 1 trauma care, and this has been demonstrated in the United States. So the big difference from the United States and Europe is that they have mainly or mostly penetrating trauma, as we have more or less blunt trauma, but so it's a little bit different type of patient. But however, if you take a patient, in this study, all patients taken to a level 1 trauma center had a better outcome, and this was more favorable for the more severe patients. So if you have a severe patient, definitely he needs to be taken to a level 1 trauma center at the first place. So now this is where we come to the triage. It's important to take the patient to the right place depending on their clinical state, and therefore we have two types of triage that we have to look at, carefully look at, is the under triage. You don't want to take a patient in the wrong place where he will not receive the right treatment, but you need also to be careful for the over triage, where the patient will be taken to a level 1 trauma centers and he doesn't need it, and you will be occupying a bed unnecessarily, and you might need it a little bit later and you won't have the place anymore. Under triage, the level of under triage that it seems acceptable is less than 5%. And over triage, to avoid this kind of gray zone for the patient that may be severe, but the clinical examination at the beginning of the care is not obvious, is considered acceptable for 25 to 50%, which is quite huge. And I think you can try to narrow a little bit down this number, because it will bring a lot of patients to a level 1 trauma centers that doesn't need to be. So you have several tools. I just give you one example, several tools to try to do a proper triage on the field. However, this figure that I'm showing to you gives you rock curves that look absolutely beautiful. These figures are done retrospectively. So the thing is that when you have a triage algorithm, you have to assess it prospectively, and we all know that when doctors are on the field, it's extremely difficult to have relevant clinical examination and all the details from, for example, the past medical history of the patient or the kinetics of the accident, to have them precisely, and to help the doctor who's doing the triage to assess the severity of the patient. So you really need to be careful when you see these numbers, and it's very difficult, and we all witness this during our clinical practice. It's very difficult to be accurate in pre-hospital settings. And this has been well described by this study published by Voskens and co-worker in the JAMA in 2018. They look at the national accuracy of pre-hospital triage to select severe injured patient, and you can see that the numbers of under triage is dramatically high, up to 63%, and this is mainly in elderly patients when you consider the mechanism criteria, and also for head injury patients who are not properly triaged. So a national triage system may not be the relevant thing to do. So what I believe, and I think that's in a certain point it sounds reasonable, is that triage algorithms should be designed to be easily used in emergency condition. The time is a key time matters, and it's a key element in the care of this patient. So you need really to make a decision. The decision-making process needs to be done in a very short period of time, so it's why it needs to be extremely accurate and easy to use. And it also needs to be tailored to every trauma center's surrounding environment. And for example, if you have a trauma patient in the Alps in France, the way to retrieve the patient to a level one trauma patient will absolutely not be the same than, for example, in Brittany. The geography is completely different, the road maps are completely different, and the ability to use helicopters is also extremely different. So I'm just going to take the example of what we are doing in France. Currently, trauma patients are triaged using the vital criteria that has been adapted from the ASCOT guidelines. And you have 5 items to assess: the kinetic of the accident, type of lesion, emergency treatment that you will start in the field, past medical history of the patient, and vital signs. We can think that vital signs and emergency treatment is not too hard to assess, but the kinetic of the accident, unless you have a witness that saw the accident, was able to measure the speed of the car, for example, and report it, this is extremely difficult to have a precise indication. The past medical history of the patient, if you don't have a relative of the patient with him, it's impossible to have this information. So a patient with, let's say, an open fracture of the femur with cardiac past medical history, and who is 75 years old, it's absolutely not the same severity than a 25-year-old healthy young bloke who just broke his femur. So you definitely need to have these details, and it's very hard to have. And the second thing, the type of lesion. When the lesions are obvious, it's easy, but when in blunt trauma, it's much more difficult to assess the lesion. And to assess them in the gutter of the street, it's much more difficult to assess them in the hospital. So to take the example of what happens in Brittany, if we're in the yellow spot will be the place of the accident. The teaching hospital and level 1 trauma center is just here. You can or take it directly to the level 1 trauma center, or depending on the triage and the availability of the vehicles, it can be taken to the nearest hospital. But what and in the nearest hospital, you don't have any trained team, you don't have neurosurgeons, the radiologists are not also trained for this, so it's a little bit different. And what we looked at is the time that it takes if you bring this patient here. How long will it take to bring it here if his state's needed? Well, you lose minimum 6 hours, whatever you do. Because the time you bring the patient to the ED, the time it's assessed, the time you reorganize the secondary transportation, it's minimum 6 hours. And as you could see in the studies I've showed you, these hours are critical for the survival. So what we did is we changed the algorithm. We adapted the algorithm, the Vittel algorithm. We simplified it, and in 3 grade. And for the grade 3 patient, we are the gray zone where you can have a severe patient that you can't really assess. We added shock index. Shock index is a quite easy tool to do. You just do the heart rate on the mean arterial blood pressure, and it is quite related to transfusion and mortality of the patient. We then end up with this, 3 grade, all go to trauma centers if the shock index is high for the grade 3 and grade 2 and grade 1, and after there's a decision here to try to avoid over-triage. And within the hospital, because in the organization of the ED department, the ED doctors are not working at the resus bay all the time. They change a lot of times, so they actually will treat a trauma patient once in a while, and you only do well what you do every day. All the trauma patients that are severe go directly to the intensive care. So we looked from we just evaluated what we did from 2016 to 2020. 607 patients that were admitted in the ICU, and we look at before and after the period, the time we started using this algorithm, which was in 2018. Basically, the characteristics of the patient are quite the same, a bit more severe. We got more severe head injury patient coming in, but that's about it. But when we look at the care that has been given to this patient regarding monitoring, hemodynamic monitoring, putting outline, putting a CVC, the time is much shorter, 110 minutes versus 25 minutes. CT scan is a little bit longer, but they all have a monitoring device, and they can also, they have a central line, and emergency treatment didn't change. If we look at the diagnosis that has been performed before and after, EFAS was performed in 62% of the time versus 41% of the time, less chest X-ray, time to fluid, given fluid is much shorter, 44 minutes versus 101 minutes, and the volume and administration is a little bit lower. If you look at the bundles of care, all the patient had a bundle of care much higher than in the post-period than in the pre-period. And patient outcome, mortality didn't change, but the study wasn't powered enough, but length of stay in the ICU was shorter for 1 day and shorter in the hospital for 4 days. And if we look at the preventable mortality, what the results showed is that, for the triage error was associated to an increased mortality, a secondary transfer was associated to increased mortality, and patient admitted to not admitted in a specialized environment, and like the ED department with non-trained physician, was associated with increased mortality. So in conclusion, time is a key component of trauma patients' care. Optimal care requires a dedicated and trained multidisciplinary team, surgeon, radiologist, intensivist, and emergency doctors. Optimal triage is a central component of trauma patients' care, and optimal triage algorithm should be adapted for each trauma centers. Thank you very much.
Thank you very much, Olivier. I think we have time for a very short question. Maybe I will just want to underscore something. You said that you need an optimal triage for the trauma center. Maybe it's more for the trauma system. It's always a networking, and you can be very operative in your hospital, but you need that all the hospitals work together and accept the same way of treating patients.
Yeah, I heard it's the term wasn't right. It's the trauma system that needs to be tailored. So you got the right patient goes in the right place. And all doctors are aware of this patient and can adapt their care for these patients. Yeah. But yeah, it's a collaborative work. It's a teamwork.
Yes, we had a good example in France with the Trauma, who first built the system. And the second very quick question, do you believe that the echography, the ultrasound, could help to the triage on the field? Because they are implementing EFAST in the field, and I'm not sure it will help to gain time, but...
we all know that echo is operator dependent. And so the more you do, the better you are. But it's always, I think if you have caricatural images when you're doing the echo, meaning that you got blood in the abdomen, that's easy. But for more precise diagnosis on the field, I'm not sure it's going to be very helpful.
I mean EFAST, of course.
Yes, EFAST, of course. Thank you very much.
Thank you very much. So we will move on with, it's my pleasure now to introduce Jacques Duranteau from Paris, or Bicêtre, France, who will talk about the vasopressin in hemorrhagic shock.
Okay, so when we have to deal with a trauma patient with hemorrhagic shock, there is clearly two phases. From the trauma, the first phase during the pre-hospital phase at the trauma bay and in the operating room, where we apply a damage control strategy. And so the idea is to try to avoid, to increase the bleeding by limiting the fluid resuscitation. And I think that vasopressor could help to maintain arterial pressure and to decrease the fluid that we have to give. And a second phase, when we, after the control of hemorrhage, where the patient, for the most severe, go to the ICU, where we have to perform optimization of macrocirculation to prevent organ dysfunction. So, a vasopressor, when we talk about vasopressor in a trauma patient, a vasopressor could be helpful in maintaining the target pressure while limiting fluid resuscitation until the hemorrhage is controlled. And after stopping the bleeding, a vasopressor could be useful to optimize macrocirculation. Right now, norepinephrine is a commonly used vasopressor as a first-line agent. And it's important I remember you the second phase, because when we think about vasopressin could be useful or not in hemorrhagic shock, in trauma, I think it's important to consider this second phase after the control of the bleeding. Because when we look at this study from Ajar, so it's not in hemorrhagic shock, it's after cardiac surgery. So they use vasopressin in this patient. It's a patient with a high level of comorbidity, with potential cardiac failure and with vasoplegic shock. And you can see that by using vasopressin, because it's important because we are always afraid to induce too much vasoconstriction, but in this patient, by using vasopressin, they improve the outcome, and it was mainly by decreasing the number of acute renal failure. So I think it's important to keep this in mind because if we want to use vasopressin in a trauma patient, we are less, we had a lower number of comorbidity than this patient. I think it could be interesting. So we know that during hemorrhagic shock, we have the involvement of the different vasopressors that we have, the norepinephrine, the vasopressin, the angiotensin II. This slide, just to remember you that during hemorrhagic shock, very quickly, for low decrease of volemia, the three main vasopressors are immediately involved. Not only the norepinephrine, but also the vasopressin and the angio II. It's very important to have this in mind because we don't talk only about vasopressor. It's not only vasopressor. They have an action at the level, for example, for vasopressin at the level of the kidney. They induce water reabsorption. They had other effects. The angio II also induce reabsorption of sodium and chloride. So it's not only vasopressor. It's really regulator of the water and the sodium homeostasis. Considering the vasopressin, once again, it's not only a vasopressor, and if we consider hemostasis, it could potentially increase the power of the coagulation power by inducing improving the platelet aggregation, by improving the thrombosis platelet-dependent secretion, and also by inducing the release of Wilbon factor or factor 8 at the level of the endothelium. So it's also important to consider this, the fact that vasopressin can increase the capacity of coagulation of our patient. So just to highlight the fact that vasopressin are very quickly involved in trauma and hemorrhagic shock. This study, it's a study where at the emergency room, so very quickly during the time course of trauma, they observe the value of copeptin. It's the C-terminal fragment of arginine vasopressin, and really the level of copeptin are really parallel at the level of vasopressin in blood. And they look at the performance of this copeptin to detect different things, to detect the injury severity score, or the ICU admission, or the transfusion. So it's interesting because for me the transfusion, it's really a good index of the degree of hemorrhage, which is very not easy to catch at the beginning of the management of a trauma patient. And you can see that the copeptin was a very good predictor of transfusion and largely better than the venous lactate. So it's just to highlight the fact that vasopressin is very quickly involved to try to restore arterial pressure, to restore the volemia. So, do we have a relative deficiency of arginine vasopressin in our patient? It could be possible. It could be possible because when we have to face to very severe hemorrhage, the three vasopressor system are involved, and maybe it's not enough to sustain hemodynamic. And this study, it's a small number of patients, but there is two other studies who show that potentially there is a deficit of arginine vasopressin. In this study, they look at the level of arginine vasopressin and copeptin, and they define arginine deficiency if they have an hypotension with a low arginine concentration, lower than 10 picogram per milliliters. And you can see that half of the patient had this arginine vasopressin deficiency. It was, and it's logical, the most severe patient with a high percentage of massive transfusion, the high percentage of vasopressor, and so clearly the most severe, but clearly patient where we need to have a good level of arginine vasopressin. So maybe it could be a plus if we add vasopressin in this patient. So I told you that we are always afraid to induce too much vasoconstriction when we use vasopressor. It's an experimental study that we perform in our lab. It's in mice, and we compare the effect of fluid alone, or fluid plus norepinephrine, and fluid plus vasopressin after a controlled hemorrhagic shock. And you can see that during resuscitation, in the three group, fluid plus norepinephrine, fluid plus vasopressin, we have same restoration of mean arterial pressure. It was in the design of the protocol, but most important, the same restoration of arterial blood flow and the same decrease in lactate. So no deleterious effect at the macrovascular level. And when we use vasopressor, we need to use less liquid, less fluid resuscitation. And it's very important because we try to do this in our patient to limit dilution. So it's a plus if we use vasopressor. But is it deleterious at the microvascular level? We look at the kidney using the contrast-enhanced ultrasonography, and what we observe in the cortex and in the medulla no deleterious effect when we add a vasopressor, and especially when we add vasopressin in comparison to fluid alone. And this was true also for the histology. We have no deleterious effect by using vasopressor. And the reason is, and it's why it's important to see that there is a similar recovery in cardiac output, the reason is that it's not only the action of vasopressor, it's also improve the cardiac output by improving the venous return. So in human, there is this, it's the only prospective study using vasopressin, not only, it's the first one, using vasopressin with the goal to see if vasopressin against fluid alone could decrease the mortality, but they had in this study problem of recruitment of patients, and they stop after 40 patients in each group. The vasopressin was used at high dose. It's 2.5 units per hour. And you can see that when they use vasopressin, they observe that they use less fluid, and they had to transfuse less patients. So clearly, once again, when you use a vasopressor, you obtain the same level of macrocirculation without giving too much fluid. So it's, once again, I think, in my point of view, in a trauma patient during the damage control phase, a great advantage. What about mortality? It was the same. It's impossible to conclude because not enough patients, but there is no deleterious effect when they use the vasopressor in comparison to fluid alone. So once again, no, it was not deleterious for the patient. So this recent study, it's in a trauma patient, and it's a study where the goal was, the primary goal was the total volume of blood product transfused, and it's a trauma patient, and they randomize the patient when they receive at least 6 units of any blood product within 12 hours. And the goal was to try to maintain mean arterial pressure greater or equal to 65, and it's a low concentration of arginine vasopressin. You can see that when at the enrollment of patient, it's the time of enrollment, because it's very important. It's 97 in the group of arginine vasopressin and 80 minutes. So it's a long time in my point of view, but it's just this delay is important to take in account to interpret properly the study. And you can see that it's severe patient with a high level of lactate. So it's the severity of patient is relevant. And so they observe a decrease in the total blood product, a decrease in the number of red blood cell, FFP, the platelet, and also the cryoprecipitate. And you see, so an efficient effect. The dose of norepinephrine was decreased in the arginine vasopressin group, but it was not significant. Another positive aspect of the study is that they observe a decrease in the deep venous thrombosis. For the other secondary endpoint, there is no change in acute renal failure, no significant, even if there is a trend, but obviously we need more patients. Just one remark about this is that you can see that the quantity of crystalloid in the two groups are high. So it's maybe it's too much, and maybe there is a deletion factor, and it's important when we talk about the number of red blood cells that we have to give. The second point is that it's not clear what is exactly the hemodynamic protocol in this study. So it's not clear when they have to give red blood cells, for example, or how they guide their resuscitation. So we have to keep in mind when we want to interpret this study. So in conclusion, relative arginine deficiency could exist in hemorrhagic shock. Vasopressin could be an alternative to norepinephrine, especially if it has an impact on organ dysfunction. Low dose of vasopressin alone or in addition to norepinephrine may be interesting in decreasing blood product requirement in trauma patients in hemorrhagic shock. And we need a larger study to determine the effect of arginine vasopressin on morbidity and mortality. Thanks a lot.
Thank you very much, Jacques. In your campaign to get vasopressin out there, are you planning some trials?
Yes.
Aha. Are they going to be national or international?
National.
Okay. Does anyone have any questions?
Maybe one. Do you think, Jacques, which is the most important, to replace a deficit in vasopressin or to use vasopressin as a vasoconstrictor? Because you mentioned two ways of using it.
Yes, I think that...
And just the second question will be, in which patients? Of course, is it only for the sicker patients, the ones who bled the most, or maybe maybe for more patients?
Yes. So first of all, I think that right now we use vasopressor just to target mean-arterial pressure. But the vasopressor we use, they are not only vasopressor. So it's important because what about the effect at the level of kidney? And what about the hydric reabsorption? The second point is, initially I thought that it was for the most severe patient, but the last study is if it has an effect really. Boosting the platelet.
Well,
I don't know if it could be interesting.
On that in a minute, but can we take the questions? Would you like to speak, sir?
Sorry for interrupting. I'm Michael Kazar from Leuven. Thank you very much because it's an eye-opener for me. I'm a bit old-fashioned and always scared about being too generous with vasopressors while not knowing whether there is a good cardiac output. So my question is, I understand now in this early phase that it's maybe really a causal and good therapy to give vasopressin. How long would you dare continuing it in the hours, days after the early shock? Would you say it should be weaned off in 1 or 2 days or some hours or maybe a week? Or?
Yes. So when we use vasopressor, most of the time it's we can stop if we have no complication after 48 hours. Yeah. So it's and rapidly decrease. We try rapidly to decrease the vasopressor. We use mainly and only vasopressor, norepinephrine.
Okay.
Thanks. Thank you.
Thank you. Thank you for the lecture. I remember the enthusiasm about vasopressin in sepsis and septic shock, and now is downgraded to a maximum of 0.04 mic per kg per minute. Are we seeing the same enthusiasm then maybe later on? So I mean, I'm just saying, what is the rationale? Are you giving low dose, or are you starting with high dose? And just more comments about that. Because, you know, the same happened with the septic shock before.
Yes, the same happened in septic shock. So, but you know, it's, I don't know how to say. We have to keep enthusiasm first. The second point is when I saw the result in post-cardiac surgery with vasopressin, wow. So I think it's, we have to try.
Can I just say, I use
Yes.
vasopressin every day in haemophilia patients and patients with von Willebrand's disease. So we give them a short infusion, and it stimulates the Weibel-Palade bodies to release von Willebrand factor. But what it also stimulates is fibrinolysis in a big way, because there's TPA in the Weibel-Palade bodies. So we have to give TXA at the same time. In all these trials you've talked about, did they give TXA?
Yes.
Too? They did?
Yes.
Okay, because it is an issue. And the other thing is you get tachyphylaxis, so you discharge your Weibel-Palade bodies and then they have to recharge. So having a constant infusion won't make much difference to certainly hemostasis.
Sorry, the dose, you didn't say the dose. Are you trying to, with the small dose, 0.04, or what is the dose you're going to try?
It's a very good question. Because I show you that in the first trial, they use a high dose. It's, I think that it depends on, in my usual practice, I will start with low dose, just to be comfortable with this. And really, because I want to be, to really have a clear idea of the potential vasoconstrictor effect in trauma at low dose.
Thank you very much, Jack, and we wish you lots of luck with your trial, and it seems like you've generated quite a lot of enthusiasm for vasopressin. We're moving on now. We have a lecture on trauma-induced coagulopathy, present and future, and we're very lucky to have Louise Deleuze from Sunnybrook Research Institute in Canada. Oh, maybe we're unlucky. Right, maybe maybe he's gone home.
It looks like.
That's a shame.
Somebody want to do the talk? It's open. But you have no slide.
Okay, shall we
So,
move on?
yes, of course. You want to introduce,
No,
or maybe we don't need to introduce
We don't need to introduce
Mervyn
Mervyn.
Singer. I think everybody knows him. So it's our pleasure to have Mervyn Singer talking about trauma.
Ischemia reperfusion injury.
Yes, ischemia reperfusion injury. So you have plenty of time, and it will be a pleasure for us.
Expand
Thank you.
out. Thank you.
He may have got the timings wrong, Dr. Deleuze. Yeah, I wanted to hear coagulopathy too. I don't claim to be a trauma expert, so my talk is more about ischemia reperfusion injury in its widest settings, but obviously there's a little bit of data I'll show on hemorrhagic shock, but I think it's the same mechanism no matter what. Okay, so there we are. We have a patient who's ill, traumatized, and clearly the treatment's important, but the treatment itself may cause harm. A few declarations of interest. I'll talk about a couple of these things later on. What is reperfusion injury? So it's tissue damage caused when we restore a blood supply after ischemia or oxygen after a period of hypoxemia and tissue hypoxia. So initially, an absence of oxygen nutrients coming to these ischemic tissues creates a condition whereby restoring the blood flow actually triggers a severe inflammatory response, oxidative damage, rather than just restoring these organs back to normal. And lots of examples of whole body reperfusion injury, cardiac arrest, severe hemorrhage, patients hypoxemic, but there's lots of localized forms. So revascularization after myocardial infarction or stroke, or when the surgeon revascularizes an ischemic bowel, cross-clamping, transplants, etc., etc. So there are lots of systemic and local conditions. And you can monitor these things and measure them, etc. This is an example of myocardial perfusion after in an animal model, coronary artery occlusion, and then 4 hours of reperfusion. So just 2 slides on sort of mechanism, but clearly when you have ischemia, yes, there are early reversible changes. I'm sorry, the transplantation from Mac to PC doesn't look quite right, so apologies for that. But essentially, you get lots of things happening which are potentially reversible, and clearly we need to intervene before they become irreversible, the injury, and we cause cell death. So, you know, there's the need to intervene. The problem is with reperfusion, that causes injury too. You get microvascular injury, which triggers an inflammatory response. You get cellular injury, and you can get cell death, necrosis, apoptosis, and all the 1,000,001 other causes of cell death or mechanisms that are now being reported in the literature. When was it first recognized? Well, in the modern era, this guy, Robert Jennings, first described it in 1960 in some dog studies looking at reperfusion after causing a myocardial occlusion infarct, as it were. However, you know, the older I get, the more I look back in time, and some clever person thought of it way before the modern era. We just rediscovered it. And my clever person here is this guy, Baron Larrey. He was Napoleon's surgeon, and he wrote about, you know, his medical experiences and what he learned during Napoleon's campaigns with La Grande Armée. Do you like the accent? And there's a sort of English translation. You can download it off the internet. But the preface said, this distinguished surgeon had opportunities of remarking that the cold is only the predisposing cause of gangrene, frostbite, which manifests itself in such cases. The heat which succeeds the cold, in other words, when you warm up the affected digits, is in reality the determining cause of gangrene. And what Larrey wrote, in perfect English, well, the translation anyway, on the night of the 10th of February, when the thermometer was 5 degrees above zero, a great number of soldiers of the guard and of the line complained of numbness, tingling, pricking, pains in the feet. Those who, while the cold lasted, warmed their digits, the diseased digits at the fire, saw the gangrene declare itself on the commencement of the thaw. On the contrary, those who rubbed the affected parts with snow and afterwards with camphorated brandy were preserved from gangrene. 200 years ago. So when I see ischemic feet and hands and the docs and the nurses are trying to warm them up, I go, no, 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 just leave them alone. Don't warm them up. You'll just make it worse. Larry taught me that 200 years ago. Well, I wasn't there, but hey. Okay, mechanisms. Lots of different mechanisms. I'll focus probably the main culprits, as it were, are this mitochondrial dysfunction. You get opening of what's called the transition pore. I won't go into any detail, and that can trigger sort of mitochondrial cell death pathways. A drop in ATP triggers necrosis, calcium overload causes cell damage, and reactive oxygen species. And so you get cell death. Those cells that don't die become stunned, and you get microvascular dysfunction. I'll just focus a little bit on mitochondria, but also activation of white cells, leukocytes you get, and other cells as well, but predominantly immune cells, NADPH oxidase, releasing lots of free radicals. So in ischemia, even though there's a decrease in oxygen availability to the cells, you still get oxidative damage. And I won't bore you through all the mechanisms, Fenton chemistry, etc., but the net result, you get carbonylation of proteins, peroxidation of lipids, damage to DNA, inactivation of enzymes, and that can lead on to cell death. So you're getting damaged cells that can die during the ischemic phase, and that's amplified by reperfusion. And some people argue, I've never seen it actually formally quantified, but the reperfusion can be as damaging, it's claimed, as the ischemia itself. So, last few minutes on treatment strategies. A whole list of things have been tried. Clearly, people are aware of the importance. The holy grail is finding the right treatment. Cooling. Obviously, cooling reduces metabolic rate, reduces ROS production, etc. And obviously, there's been a long checkered history with therapeutic hypothermia. So this came out 2002, 20-odd years ago, suggesting benefit after cardiac arrest in terms of favourable neurological outcomes and death. Unfortunately, this early study has not been replicated. This is a big trial, the TTM trial, targeting 33 versus 36 degrees. No effect whatsoever. Why? Well, the reperfusion injury begins immediately, but look at the time before they got to their target 33. It took them about 8 hours, and that's for half the patients to get there. So again, you're getting the injury, and the intervention doesn't come in until a large part of the injury's already happened. And the same story here. This is a Eurotherm study on traumatic brain injury. They had to stop the trial early because of harm when they tried to cool patients down. And again, as you see here, it took them a day to even get into the range that they were striving for, and 2 to 3 days to get to the target value. So again, too slow, too slow, too slow. And recently, this came out a few weeks ago, New England Journal, the TTM2 trial. If at first you don't succeed, try again. Oh dear, didn't work. And the same problem. Look how long it took them. 34 degrees, even, was it about 5-6 hours? Only half the patients got there. The horse has bolted already. What about drug treatments or more aggressive cooling? David Erlinger is a cardiology professor in Sweden, and he's been had a long-standing interest in this area. So 120 patients with ST elevation, myocardial infarction, and it was very aggressive cooling. So they gave approximately 1 litre of 4 degrees centigrade saline and an endovascular cooling device, started before angioplasty, percutaneous intervention, and continued for 1 hour afterwards, aiming for a target temperature of 33. And these are in awake patients, and they had to give them haloperidol and or droperidol or something to stop them shivering because they were awake. However, in terms of overall results, so the infarct side, so you can see on the left-hand side, you can see that they actually were pretty good. Didn't get quite to 33, but they got to 34 pretty quickly. And obviously the patients warmed up afterwards. But in terms of the infarct size as a proportion of myocardium at risk, so you do that with MRI or etc., you can see there was no statistically significant benefit. However, a composite outcome of death or subsequent development of heart failure, there was a benefit from this very aggressive approach. A group including Erlinger put together a sort of meta-analysis, 312 patients, not huge numbers, 6 studies, and essentially what they found, if you got the temperature down aggressively, below 35, it worked for anterior myocardial infarctions, the more severe infarction, but it didn't work if you didn't get the temperature below 35 or for the inferior MIs. Other things, so cyclosporin, obviously, you know, it's calcineurin inhibitor, but it also blocks something called cyclophilin D, which is related to this mitochondrial transition pore, permeability transition pore, which opens up with ischemia and reperfusion, causing cell death. This early trial from France suggested benefit. Small study, and they looked at injury infarct size, looking at creatine kinase, troponin levels, and an MRI at day 5, and there was a suggestion of benefit. However, when it was repeated in a much larger study, nearly 800 patients, made no difference. Again, don't know why. One worked, smaller trial, the bigger trial didn't. Other drugs have also tried looking at blocking this mitochondrial transition pore. Again, no difference in a human study. What about fruit? Well, fruit impairs apples. You have something called mevalonate, which blocks succinate. And succinate's been shown to accumulate with ischemia. So when you reperfuse, that increases the amount of reactive oxygen species produced by the mitochondria. So Mike Murphy, who's at Cambridge, and colleagues, basically did some very nice animal work, basically showing that succinate shoots up with reperfusion. So if you block it with your pears, apples, whatever, or give mevalonate, there was an improvement. So they showed a reduction in infarct size, and in a stroke model, they showed the same. Hasn't yet, to my knowledge, gone on to patients. I think they tried in an animal model, and a pig model, a big animal model, and it wasn't, as far as I'm aware, successful. What about hemoglobin? Hemoglobin's actually a very good scavenger. And so we've done some work with some actually Hong Kong companies looking at sort of modified bovine hemoglobins, and we're doing something with a university in Essex in the UK where they're doing recombinant hemoglobin made from E. coli. Interesting. But it's human hemoglobin, but made from E. coli. And we're giving small amounts, and not enough to really raise the hemoglobin significantly, but to use it as a scavenger. And this is in a hemorrhage resuscitation model we have in our rats. And you can see that the survival was enhanced. So we gave the drug at the time of resuscitation. So I can't remember, I think it was about half an hour of severe hemorrhage, and then at the point of resuscitation, like, they either got this bit of hemoglobin or they didn't, and you see it's just 400 mg per kilo, and you can see isoprostanes, which are a marker of lipid peroxidation, was significantly reduced. The other final drug I'll talk about is something we came across by chance. There was a lot of interest a number of years ago about sulfide, so rotten eggs, essentially, and rotten eggs basically, apart from being anti-inflammatory, can also switch off your mitochondria and decrease ROS. But I think probably the initial groups went in too quickly with sort of a hydrogen sulfide liquid form that basically caused side effects and not the direct benefit. But we, by chance, came across this drug called ammonium tetrathiomolybdate. So it's molybdenum core with 4 sulfur atoms, and it seems to get into the cell and release 1 or 2 of the 4 sulfur atoms within the cell. And we found that you could infuse it into rats, and let me just find the pointer, and essentially you could inhibit oxygen consumption by about 20%. That was a 24-hour infusion, and at the same time, this is at 24 hours, the temperature was lower, the heart rate was reduced by 1/3, but the animals looked all right. They were still eating, drinking, but they were less metabolically active, a bit like my medical students. And we've done it in models, which we try and simulate real life. So this is a heart model. Again, clamp the left the descending coronary artery, and you can see here the ischemic side as a proportion of area at risk significantly reduced with the drug. BNP levels as a marker of ventricular dysfunction reduced, and here's just a sample, but you can see slices through the heart, you've got much nastier infarct, whereas the drug seems to preserve it. And again, we gave the drug at the point of revascularization. So likewise with the brain, and we did this with a colleague in Brazil, and again, similar effects. Infarct size is reduced, S100B as a marker of brain injury reduced, and that's a global hypoxemia model We've also done it in hemorrhagic shock and shown better survival after 4 hours. And this is an MCA occlusion model, and it's pretty obvious. You can see the infarct at the top, lots of white bits, and it's much better preserved with the drug. We've just repeated it in pig models, of a pig model, a 60-kilo pig model of myocardial infarction. This is at the University of Bristol, the veterinary school there, and basically the same. So hopefully we want to see if it can work in man. So hopefully next year we'll do some early first-in-man trials. So in conclusion, reperfusion injury is a major cause of organ damage after the ischemic event. Major players include this excess of reactive oxygen species, calcium overload. It's potentially treatable, but we've got to get there early, intervene early. Lots of strategies, yes, lots of animal models showing the work, but we've now got to reflect that into human better outcomes. Time will tell, but I think hopefully we're on the right lines. Thank you very much for listening.
Thank you, Mervyn. That was very entertaining. Fantastic slides. We have a question. Do we? No? Yes.
Running. Hi.
Thank you very much for the nice presentation. The problem, of course, is that we're always too late, is what you show from the clinical data that we have. And this is not easy to improve, I'm afraid, because most of the cardiac arrest patients, for example, are not in the hospital before they get the cardiac arrest, which would be nice. And then another thing is that many of the drugs which are being tested currently, either in animal models or in human models, they only attack one of the steps in this very chaotic and large reaction, which changes over time. So I was wondering, wouldn't it be a better approach if we kind of start to investigate a cocktail instead of just this one blocking stuff? So what's your idea about that?
I 100% agree. Unfortunately, this is the sad, pragmatic reality of the world we live in. You're not going to get a drug company, because essentially to get to the big trials, unless you're lucky to get some sort of academic funding, but to do a big trial, companies don't want to invest unless they own both products to go both. So we're stuck at the moment with one. I think my hope is, and I completely agree with you, you try one, show it works, and then you may be able to add others in to see if there's added benefit. And your point on cardiac arrest, completely agree with you. Again, people I'm doing the drug development with, they're saying, oh, what about cardiac arrest? And I said, yeah, but it needs to be given by the paramedics, not by me, by the time they get. Completely agree.
The problem is that the companies might have to realize that investigating one substance will not, and you say it will prove effective and then we'll go on.
Yeah.
That will not be the way.
Yeah, I know, but that, I agree with you, but the sad economic realities unfortunately argues against it. But you're completely right. But that's why I'm hoping we could just get sort of synergism happening later on.
Mervyn, may I have two quick questions or common question? You insist a lot of hypothermia as being protective, but in the context of trauma patients, we are fighting hypothermia because of the coagulopathy. So what will be your recommendation with the hypothermia, because our patients are... I'll ask the second after.
Well, I suppose, I'll throw it back at you guys. At what point, because cardiac surgery, they get hypothermic. So there is a rationale for doing it, and they don't get markedly coagulopathic. So obviously the trauma itself has induced an insult, and clearly it's benefit and risk. So how, I'd be very interested for your feedback, because I don't claim to be a coagulopathy expert, but, there's clearly a benefit from being cooling, but when does that benefit spill over to being harmful? And it may be, again, a lot of the hypothermia, all right, sometimes the patient comes in cold because they've been in the field for a long time. But, so half of me thinks there is a role for it, but it's, I suppose the $64,000 question is how we do it, to what level, and perhaps what else we should do to mitigate harm. I don't know if you guys want to talk about coagulopathy. I think Bev might have a comment there.
I think that in cardiac surgery, when you use hypothermia, you are coagulopathic. You have it because your enzymes won't work well, and you're absolutely dependent on a cardiac surgeon with meticulous surgical hemostasis. And if you don't have that, as you rewarm, then you have a lot of bleeding problems, which you have to deal with. So I think it's difficult. We have another question.
Yes, thank you, Professor Singer. Just about the ischemic reperfusion injury, it depends on the time, because sometimes the reperfusion can be very important if the ischemia is not that long. So can you give us an idea about the time? I mean, because you know, we work in, for example, in liver transplantation, and we like to reperfuse very quickly.
That is a really good question. We haven't actually published it. We've got some sort of animal data, admittedly. But again, is it a very rapid decline and a rapid recovery? Is that better or worse than a more gradual ischemia followed by a more gradual or a rapid resuscitation? And it's quite interesting, actually. I think a more prolonged period of ischemia, at least in these early studies we've done in rats, seems to be more injurious than a very rapid sort of hit. So again, it might be, you know, and I think we've got to learn more about it. But I think, you know, it's one of the problems. I think obviously you guys will talk better than me on liver transplantation, but now there's a huge amount of work now going on to try and maintain the donor organ in a much better condition before putting it into the patient. And I think now people are looking at antioxidant therapies and so forth to try and mitigate against the reperfusion injury. So I know it's a sort of ongoing area, and they're giving lots of substrates during the sort of transport of the organ. So I think, you know, they're thinking on similar lines. How can we, you know, obviously protect the organ from the patient, as it were, with reperfusion?
I think that's fantastic. Thank you, Mervyn.
Thank you.
And not only have you given a great talk, but you've prepared the way for the next speaker by moving on to talk about livers. And it's a great pleasure to introduce a colleague from my group of hospitals, Jules Wendon. She's the queen of livers, as far as I'm concerned. I know she's from Mervyn too. And she's going to talk to us about liver injury. Thank you.
Thank you for that kind introduction. I'm certainly not an expert in this field, and in terms of declarations of interest, definitely enthusiasm and optimism. It is my hallmark, probably, but I am neither a liver surgeon, liver transplant surgeon, and I'm not a traumatologist. I'm a liver intensivist. The management of liver trauma, however, has changed considerably, and it really does require a multidisciplinary, multi-professional approach. And so hopefully I'm going to cover some of those areas over the next 12-15 minutes, but I would emphasize that this is a very clinical talk. This is not science. This is what we do at the bedside. So there we go. So first of all, a bit of anatomy. Remember, in terms of the liver, that you have your central hepatic vein, and then you have these little triads, which involve the hepatic artery in addition to the biliary tree. And whenever you've got arterial injury, you will also have biliary injury. And as such, you will have a risk then of biloma, and as we'll see later, pseudoaneurysm formation. The liver has a dual blood supply from both the hepatic artery and the portal vein, high pressure and low pressure systems. And in terms of the liver again, it's a beautifully segmented organ. Each of these is independently functioning, so to speak, and most blunt liver injury involves segments 7, 8, and 6, 5 and 4, much more for central blunt injuries, cycle handlebars and the like. Deceleration injuries can be significant in terms of the liver, putting the IVC and hepatic veins at risk, and children are particularly at increased risk in terms of their flexible ribs and less connective tissue to support. So we have both blunt and penetrating injury. It's stating the obvious. It's also very important to recognise that we induce a moderate amount of liver injury in our own clinical practice, both by liver biopsy, intercostal chest tubes, and also important to consider the spontaneous rupture, preeclamptic livers, amyloid livers, adenomas, and the like. And these all need to be managed in a very similar manner. Going back to Mervyn's comments, if you get it wrong and you excessively pack these livers, you can cause phenomenal ischemic injury and end up in a really difficult place 48 hours down the tree where you're wanting to decompress the patients. And associated organs must be considered, particularly pulmonary and cardiac contusions, spleen and duodenum. And a recent publication shows this nicely. This is in Blunt Liver Injury, significant numbers of patients showing the coincidental injuries that must be considered, both perhaps extra-abdominal and intra-abdominal. So in terms of classifications and pertinent in terms of your optimal management, you've got your minor liver injuries, the American Association grading grades 1s and 2s, the moderate grade 3, and moving on to the more severe grades 4 and 5 and 6, where you've got vascular hepatic avulsion, and these patients rarely get to trauma centres. Occasionally they do now with aortic separation, but it is rare. And just some images now. As I said, this is a very clinical presentation. It's a grade 3 liver injury that you see on the left here, by contrast to grade 5 liver injury involving more than 75% of the liver lobe and with juxtahepatic venous injuries. In terms of liver biopsy, this is someone whose liver biopsy has managed to induce an arterial portal fistula. So you see arterial flow and portal flow highlighting at the same time in terms of the CT imaging, and also the associated significant subcapsular hematoma. And given, although it's not quite the same as the kidney, livers have really quite tight capsules around them. Until that capsule ruptures, and sometimes it will do, you will get significant ischemic injury by virtue of that perihepatic hematoma, and that needs to be considered also in terms of your management. This is where we managed to put a chest tube, weaving the generic we, through a liver. You see the chest tube here, you see the associated liver injury here. It was managed with packing, and then the packs were removed at 2 weeks. The patient appeared to be doing well. What was then of concern is that the patient developed further hemodynamic compromise 2 weeks later, and you see here the pseudoaneurysm that was bleeding, requiring embolization. A pregnancy-related liver rupture. This is someone who postpartum, who was preeclamptic, complained of right upper quadrant pain, chest pain, AST of 200 at baseline, hemoglobin of 11 or 110 now. You see the age of this slide. Because it was assumed, perhaps rightly, to be pulmonary embolic, they were heparinized with the associated consequences of significant liver bleeding associated with the rupture. I'm going to skip that slide. So there have been some very nice recent reviews looking at how you might formulate a plan for these patients. This was published this year in the Scandinavian Journal of Trauma and Resuscitation. You see that really everyone needs the ABC fast, and the majority of patients should now get a CT scan. Many of us now will trauma call our patients within the CT scanner area to ensure that we get that imaging. Your severe liver injury coming down here, if they are truly hemodynamically unstable, you will have to go to theatre for damage control surgery, push, pack, Pringle now rare, but importantly, the plug component we must look at. And the vast majority of patients can go down this right-hand model where you can control the arterial bleeding with embolization and plugging. And this is a really nice image of that. Push, pack, plus minus Pringle, increasingly now push, pack, plug. And I just show you this. It's a nice demonstration of that. What's really important in liver trauma is not to pack the open book. The damage to the liver does not need to be packed. You need to push the liver together. The packs go around the liver. You can explore the open book, tie off any vessels within it, diathermy those vessels if needed, and then pack around the liver. I'll just let this flow for a few seconds. You'll see, but down there, a bleeding vessel that surgically skilled hands are tying off. And subsequently, they come up that breach in the liver, diathermy at the surface, and then push the whole liver together in order to gain control. Given time, I'm going to move on. So, push, pack, diathermy, suture, hemostatic preparations. Coming back, we want a warm patient in order to facilitate clotting. We want to use appropriate coagulation factors, thromboelastography, and one bit of advice which I still like, provided by our liver surgeons, is sometimes stand back, have a cup of tea, allow your coagulation experts, your anesthesiology experts to get it together and sort things out. Stop rushing. Similarly, these guidelines produced last year, much too detailed to go through today, but important to say, again, they align with that image that you saw before, and importantly, also emphasizing both pseudoaneurysm risk, biliary tree risk that can be managed endoscopically, and the importance of thromboprophylaxis once you have got immediate control of your bleeding point, usually with low molecular weight heparin. And again, this is described in this by this team in terms of the more stable liver traumas, minor, moderate, and severe lesions, going through CT, going through embolization. If you can't embolize, then you will have to go to the OR and pack. And similarly, for the more severe end, again, you have a really nice flow diagram, recognizing now that increasingly we are using REBOAs for the hepatic avulsions with some success. Going back to vasopressin, we don't use it as routine, but this nice animal study, albeit quite old now, looking at porcine liver laceration, vasopressin alone, high mortality, vasopressin plus fluids, and improved mortality, very small numbers. These are pigs, fluid alone poor, vehicle plus fluid poor. And so there is something potentially about vasopressin in this field, but perhaps more salient is that this is damage control resuscitation. It is avoiding giving excessive amounts of fluid, getting volume overloaded, particularly pertinent in the liver setting where you do not want right-sided congestion, which will cause excessive bleeding within the liver. And as you see here, particularly on the left-hand side of this slide, of those patients reviewed with severe liver injuries, pre-damage control resuscitation, much higher operative intervention. With damage control resuscitation, you can increase your non-operative intervention utilizing embolization. And also seen on this slide, similarly, as the volume of fluid was mitigated, we saw significant improvements in survival, particularly of all factors related to the resuscitation process. On multivariate analysis, injury severity score, as one would expect, but also the amount of red cells transfused was significant, GCS, as one would suspect, and also non-operative liver management being protective in terms of outcome. Again, this is just 3 studies referenced here to emphasize the need to consider and enact DVT, venous thrombosis prophylaxis. You do not want your patient to die of pulmonary embolus once you've got control of the immediate bleeding. And this is seen, I bring this up I think it's a salient observation. This is a study looking at hepatectomy and Whipple's, emphasizing the thrombotic tendency of the hepatectomy patients. Although their INR goes up, their 83 goes down, and they have an increased endogenous thrombin potential, and liver patients with injury are similarly thrombotic. Again, some images. This is a pedestrian versus a bus. This is CT trauma call. You see here, this is hepatic artery bleeding going across here. The patient went straight to embolization. This is the bleeding point, and this is post-embolization, a nice area. They then had to be packed in order to get control of the venous bleeding. Pseudoaneurysms are important. They often present as hemodynamic instability, 1 to 2 weeks post-trauma. You might see obstructive liver function tests. You might see melena and hematemesis as blood travels down the biliary tree into the GI tract. This is the sort of image you see, the recovering liver injury, the bleeding vessel here, seen on angiography and subsequently embolized with good effect. In terms of biliary injuries, one needs to be considerate of these. We don't put drains in so much anymore, so you don't always see the bile coming out of the drain. So if you've got fluid in the abdomen, consider needling it. If it is bile stained, you don't need to surgically correct this quite often. You can proceed with ERCP. You see here on the ERCP, the peripheral loss of dye here. This is the bile leak, and you manage to control that with a stent across the sphincter of Oddi. If you have high duodenal pressure, that clearly won't work. You then do that, plus you insert a nasobiliary tube in order to drain to atmospheric pressure. So again, you can avoid surgery. The associated injuries, do always consider the pancreas, particularly if you've got acidic fluid accumulating, send for amylase. That can also be stented very successfully, and diaphragmatic injuries as well, quite difficult to diagnose, but they are associated with major liver injury. So, in summary, Chairman and ladies and gentlemen, things have changed over time. This is much more a multi-professional, multi-speciality management now, involving particularly surgery, anesthesia, coagulation, radiology, and intensive care. It needs teamwork, and that's what makes it such good fun and allows us to make progress in terms of outcome. Thank you for your attention.
Thank you very much for this very amazing talk. Is there some question from the... No? I have maybe one question. You pointed out that non-operative management is now the priority. And a clinical question in my institution is always, when do we control the CT scan after the first trauma? I mean, in not too severe patients, not the polytrauma in the ICU, but the one, and when do you authorize the patients to go back home after single trauma, liver trauma?
So I think that's a really difficult one, isn't it? So we get everyone through the CT scanner. Most people then, if they've not had an embolization as part of their management, we will aim to re-CT them at a week.
Okay, so we are moving to 2 days now. No?
Yeah, so we will do it at a week. If it is someone that we want to send back to another institution because they're not our local patient, we will do it earlier, but ask that other institution to also consider imaging and bring them back to us. But I'm interested that you're doing it at 2 days. That would cut down time a lot.
The question is, when do you are able to diagnose the pseudoaneurysm? I think it could be earlier. In spleen trauma, it has been shown that it's very quick after the trauma. So that's the only question we ask to the second CT scan is there a pseudoaneurysm that needs embolization or not? Yeah, and I think, as you say, some of it is the time taken to form the pseudoaneurysm that you can see adequately on imaging. Yeah. Absolutely. Thank you. So maybe, Beverly, you want to close the session?
Well, thank you. It's been a fantastic session. And I've really enjoyed it. I think you'll have a lovely lunch. See you after lunch.